Hello, and a massive warm welcome to Module 4 of your Level 4 Low Back Pain qualification. My name's Hayley, and today I'm taking you through the entirety of understanding the ins and outs of specific low back pain. So this one really does build on what you learned in previous modules. So the last module we learned a lot about posture. We learned a lot about what's going on a non-specific low back pain, which is obviously where somebody's going to start off in their diagnosis process, even if it ends up becoming specific in time. Now, in this specific low back pain module, we're really dialing into the nuts and bolts of what's happening, what are these formal diagnoses of what people have when they are diagnosed as having specific or nerve root based low back pain. Now, we're going to build on what you learned in Module 2. Now, we dived into some serious amount of anatomy and physiology in Module 2, which allowed you to understand the pathology of the bone structure, of the active muscles and fascia, allowed us to understand the nerve integration as well. So now we're building on that to understand what parts of those have a formal diagnosis as well. So in this module, we're going to look and define what specific low back pain is. We're going to understand 7 key specific spinal pathology conditions that exist. Now, these are specific, as the word suggests, and spinal pathology means that there's physically something going on in the spine or in the passive structures around the spine in particular. And we're going to really look into those 7 key conditions in particular. We're also going to define your limitations of practice. So there's some areas where we can't work. There's some contraindications to exercise now because these guys are quite a lot more at risk than with the non-specific low back pain because there is physical damage that is occurring in their spine. Now, there's also a way of understanding treatment for this specific low back pain. There's a different type of treatment for this in comparison to that for the non-specific, so we're going to learn all about that in detail as well. And then we're going to complete some learning tasks just like we have done in previous modules, but we're also going to spread towards now starting and continuing alongside that case study, alongside the worksheets which should already be complete. So let's head on through and really understand what's going on. Now, with specific low back pain, when we were talking about non-specific low back pain, we knew that the definition of non-specific was really that they had no diagnosis at all and that they had been tested for all of these specific changes in the body and been scanned and had MRI scans, had specific tests done throughout their body to check for nerve root pain, to check for deterioration around the spine itself. Now, if in those tests they notice that these things are going on and they can physically pinpoint what's happening, then it will be classed as serious spinal pathology or specific low back pain. Now, these are some of the words and titles of these specific conditions that we're going to look at. We're going to investigate 7 of these. Now, they are some long words, and these make you very glad you don't have a multiple choice quiz to answer as part of it, because they're long wording and we're not asking you to spell them, thankfully, but it would be advisable that you are able to recognize them. So if you get a letter from a GP and it's got these words written on it, you've got to be able to understand which one that is. And again, I would always make sure that you have that written down from a GP, because it's easy for your client to just pronounce these a little bit wrong and us understand it as something different going on. So this will make more sense as we head on through. To start off with though, let's read on down through these 7 conditions we're going to do. So spondylolysis and spondyloliphysis, then we've got spondylosis, we've got spondylitis and ankylosing spondylitis, we've got spinal stenosis, disc herniation, scoliosis and cauda equina. Now there is, like I say, some long words in there and they'll make more sense as we head on through the module. So let's start off with spondylolysis and spondyloliphysis. Now, just look at the images here at the top, and this will give you a really good understanding of what's actually happening. Now, first of all, just look at the anatomy of what's happening here. Just bear in mind this is somebody that is facing towards the left-hand side of your screen. Okay, so they're facing towards your left-hand side of your screen right now. And you can see the vertebral bodies with the intervertebral discs in between. You can see those really, really clearly. And that's really nice and clear and easy to see. But then usually where we have then the lamina, which then reaches out and around where and creates a circle that allows our our spinal cord to go down through the middle of, and then it produces all of these spinous processes and transverse processes off the side for attachment. So there's a vertebral body, and then you've got the lamina, which is that extra bit on the back which reaches towards our posterior. Now, in that space, this is where there is a potential place for a weakness, and that's a small stress fractures can occur. Now, if small stress fractures occur in this place, and you can see where the arrow is pointing, then that, just as a stress fracture, is classed as pars interarticularis, and this means that it's partly articulated, so it's a small stress fracture. And this in particular, as this starts to occur, this is the beginning of what then develops into spondylolysis. Now, as a stress fracture here, that could be caused by just a genetically thin vertebra. It could be overuse, and actually a cause for this has been big high impact, especially in underdeveloped adolescents doing really big impact-based sports. So, for example, rugby, whereby there's contact and impact. And then this causes this little stress fracture to occur. This is most likely around the 5th lumbar vertebra. It can happen on the others, but it is most likely around that 5th lumbar vertebra, so L5. And the reason that this is most likely here is because that's the place where the most amount of pressure of all of our body weight is sinking down, and then changes course as it heads in towards the sacrum. And there's a huge amount of pressure at this point. Now, as that pressure is then pushing down into the sacrum, it can then dissipate out into the pelvis, but there is that one weakened point that if people do get this spondylolysis, then that's generally where it occurs from. Now, spondylolysis is where that small stress fracture now develops and becomes totally detached from the body of the vertebra. So you can kind of imagine this kind of totally detaching away. You can see it in that middle image now, that stress fracture has allowed that to totally pull away. Now, remember, we don't just exist on bones and intervertebral discs. We've got ligaments, we've got muscles, we've got tendons, which are keeping all of this in place. So we may not even notice that we have a full separation here, so a full detachment, which means that we may have spondylolysis and not even know about it. So it can be asymptomatic and just be indicated by pain in that area. However, as that progresses, especially depending on the condition of the ligaments and the muscles, depending on the treatment process and how early the spondylolysis is found out, is diagnosed, then that means that it may well develop into spondylolyothesis. Now, this means that there is detachment, like with spondylolysis, but now displacement as well. And you can actually see the difference. Can you see the pressure on that final intervertebral disc, that you can now see the difference between the second image and the third? Now, if you see that pressure on that disc, that's going to be very painful, but also you can notice that that gap has got bigger, and that actually it's allowed full displacement, which means that they're more than likely to be pushed into an anterior tilt, whereby there is very, very weak stability around that area. So really, really fragile, a lot of pain, and it can be painful to cause any kind of motion around that area as well. So they might be limited in being able to even get towards a posterior tilt. They might be able to not be able to move any further into anterior. They could be totally disabled from their pain, i.e. not being able to sit down or stand up or transition between the two. So at this point, it's knowing what is going on with these types of conditions. Now, first of all, if you have a client that's coming to you with just a small stress fracture, we already know we don't want to be putting in lots of impact in here, because that's potentially going to push it towards spondylolysis or spondylolisthesis. And that goes across the board. It's a case of really working with them where they're at, but not making anything worse. Now, these guys, in order to get fixed, are going to need an operation unless they are asymptomatic and strong enough to hold just off the tendons and ligaments and muscles. but generally this will be bolted, so it will get pinned back together. Now if you're working with somebody that has, and generally they'll fuse, as well, so they'll take out that final intervertebral disc. You see that on the spondylolisthesis. They take out that final disc and they'll sort of use a cementing process to make that all fuse across. And that means they won't have any movement around that L5 intersacrum at all. However, it will be much better than the pain that they're experiencing currently. So generally it would be an operation that would be probably their own treatment out of this. However, they may well be on pain-based treatments right away because of obviously the pain that's being pushed on the spinal nerve, the pain from the actual positioning as well, and the pressure that's putting across the discs and across the whole structures of the body. So really my thing is to be very careful. Be careful about lots of posterior and anterior tilts because you don't want to do anything that causes pain. You can work with them through levels of discomfort as long as they are still okay with that. As soon as it becomes painful, ask them to stop. So really the exercises that you choose to do are more about promoting general activity in their life. They're more about keeping them moving, keeping their general health tip-top, as much as squeaky clean inside as they can without a deterioration in their health just because of their back pain. So really here you're talking about prevention of ill health in terms of activity and getting them moving rather than a case of treating or using specific corrective exercises via their exercise choice. So really you're looking to just keep them moving, keep them active and limit their pain as much as possible. So that's the one with the long words. Now we're going to look at spondylosis. Now this is a lot more common than the first one that we went through. Now over time, this develops over time. So spondy means of the spine, and that's why you've seen a lot of these have spondy at the beginning. So great image here. This is actually of the cervical spine, which is why the cervical vertebrae look a little bit different in shape, but a really clear imagery. Now you see it's looked at from the side view, so you can see the vertebral body, and you can see the intervertebral discs as well, and then you can see that there's actually really long spinous processes on these for your right up on your neck, and that's what's similar for the cervical spine, so that's what we'd expect. It does look a little bit different further down on the lumbar, so the difference is not that right now. The difference that we're looking at is that on the first image, can you see there's a really nice clear gap between the vertebra and the intervertebral disc? Kind of looks nice and regimented, whereas over on the right hand image you can see these little bony spurs appearing that overlap to the point that you can't really see the intervertebral disc in there. Okay, so over time, especially as we get older and potential illnesses as well, our intervertebral discs will begin to dry out and they'll start to weaken. So they dehydrate and they weaken, and that means that the disc starts to collapse, it starts to lose height. And as a result, the bone starts resting on bone. And then depending on the posture that person's taking, it will start to increase the pressure that's going through the little facet joints. Now these facet joints up here are where the transverse processes and the vertebral body itself sit on top of the one underneath it. So it's where they align, like we went through in Module 2. Now, over time, this pressure around the facet joints, pressure around the outside of the vertebral body starts to degenerate all around the bone itself. And the bone starts to degenerate, the discs collapse further, and it starts to get bone on bone wearing away, which is what we know as osteoarthritis of the spine. So as this is wearing away, the cartilage that covers and protects the joints start to wear away as well. Now, the body starts to regenerate its own bone growth, so it's like it just wants to get everything better again, so it starts to regenerate bone growth. And this is similar to, say, if you file your nails down, so this might be one for the ladies in particular. You file down your nails, they grow back even quicker rather than if you, say, just cut them, for example. So as you're filing it down and that new bone is stimulated to be grown in its place. However, it grows in an irregular pattern. It doesn't grow how it has been filed down. that would be fantastic. But it grows into something called bony spurs, and these spurs you can see on that right hand image. They kind of jut out at all different angles, and they can actually cause a self-locking motion, which means that if you think on the left hand image, that person would be able to rotate side to side like you can do in the cervical spine. Whereas in the right hand image, if that person is to now rotate their head side to side, not only is it going to grind, is it going to feel really uncomfortable, they're going to get the pain of bone on bone, but they're going to also potentially have full locking, which means they might not even be able to move that full range of movement as expected. And this again is where those objective assessments come into play. So you can see what your client can actually do. What range of movement do they have when they turn their head to the left? What range of movement do they have when they turn to the right? What spinal motion do they have in their lumbar? Really test it out so that you can understand what's happening. Now this is basically osteoarthritis of the spine, spondylosis. But as it starts to break down, that's when the bony spurs start to appear, and that's when we call it spondylosis. And this is what a common problem in older adults in particular, especially to do with back pain. It can cause a lot of pressure around the actual spinal nerve, so the actual main spinal nerve that drops down through, because our actual space in between our intervertebral bodies starts to become narrower, and we end up with less of a space in our spinal canal. Now as that spinal canal starts to reduce in size, because these bony spurs start taking over space and cause more inflammation, then we end up with something called stenosis, which is the next one we're going to look at. It just means an impingement around the nerve itself. But before we move on to stenosis, just want to really clarify that in this position with the spondylosis, it will vary massively per person. They may get pain some days more than others, depending on their hydration levels, very important. If they're able to sleep lying flat, then it's much advised, because that will help with rehydrating the disc itself. It will also mean that they may experience pain in particular motion, so they might find it very painful, for example, to flex forward, or they might find it very painful to extend. And it's a case of just listening to that client so you know what's specific for them. And that's really what makes specific low back pain so interesting, is it's different for every single person that you will come across. Now, operations for this and treatment for this generally relate to an arthroscopy, whereby they're going to go in and they literally file away some of these bony spurs. The other option is that they literally remove the intervertebral disc and they fuse it using like a concrete kind of material, which means that they fuse that so that no movement can happen in between those two vertebral bodies. So as a result, it means that movement is very limited, but at least they don't have pain, and at least they don't have any pressure on any of the nerves as well. So there's a couple of options there for treatment. Some people will just be asked to strengthen the muscles around that area, remain active, keep circulation, keep hydrated, and make sure that they are taking regular rest intervals as well. And that will basically allow them to have a manageable level of pain as well. So there's a couple of options that you need to be aware of that people might be going through in their treatment plan. Now let's look at spinal stenosis. So this is a really good view of the top of a vertebra. And actually earlier we were talking about this lamina, this sort of ring-like that goes around the spinal cord. So I just want to highlight that before I carry on. Now this bit, you can see the vertebral disc is, the vertebral body with the disc sat on top of it. Now, so we're looking from the top, looking down onto the vertebra itself. Then you can see the hole where the spinal canal sits, and that's where your spinal cord runs down through. Now, this circular bit around here is classed as the lamina. So when we're talking about the fracture that occurs, that's occurring on this bit of bony ring that goes around the outside of the spinal canal. Then you've got your spinous processes jutting forward, your transverse processes out to the side, and then you've got those little knobbly bits that the facet joints can sit on top of each other to allow movement between the two. So that's kind of an overview of what you can see right in front of you now. Now, spinal stenosis is a condition whereby the actual spinal canal starts to be narrowed, it starts to become narrowed. And there's a couple of different reasons for this that it may occur. However, as it does it, it pushes pressure all the way through the spinal nerve. Now, depending on where that is occurring, whether that's up in C1 or right down in L5, it will affect where the pain is then radiated to, or what the effect may be. Now, this is actually quite serious, because if you think spinal cord running down the middle is in charge of everything in our body from a control point of view. And if there is a cutting off or damage or a restriction happening at one level, that could mean that there is loss of everything below that. So it can be very, very serious, and it can relate to a few particular conditions. So it's almost a symptomatic process of another condition. So it can cause a lot of pain. It can cause numbness and weakness in the legs. It can cause discomfort in particular positions as well. And some of the causes of this include the bony spurs we were talking about in spondylosis a moment ago. So if you just imagine those bony spurs that we were talking about starting to accumulate around the vertebral body, and then starting to kind of push in towards that spinal canal, you can see them starting to develop around the facet joints here compared to the left-hand image. Those bony spurs are starting to stick out into that spinal canal, which is going to put pressure on that nerve and cause pain over specific movements. Then you've got things like osteoarthritis and rheumatoid arthritis. So rheumatoid arthritis in particular is an inflammatory response. So it's generally down to a lot of inflammation in the body, but it's an autoimmune response. So it just happens in the body. It's the body attacking itself around the muscle lining in particular. So here, it could be around the muscle, the tendons, the ligaments that we have all around this area that can start to get inflamed, and that can cause stenosis as well. So if you remember in Module 2, we spoke about the longitudinal ligaments that run down, some of them anteriorly down the front, but also the posterior longitudinal ligament, which actually runs down along the spinal canal. Now, if that becomes inflamed because of a condition, because of a wear and tear, maybe they've damaged that ligament and it becomes inflamed, then that can start to put pressure on that nerve as well, and that would be classed as spinal stenosis as well. The other things that can also cause inflammation is ankylosing spondylitis, which is another autoimmune condition. We're going to go into that in a little bit more detail on the next one. But generally, any sort of autoimmune condition that can be causing this, the conditions could still be called spinal stenosis, because it's just about the narrowing of that spinal canal. Now, this means that you need to avoid any movement that causes direct pressure on that spinal cord and causes pain. So I used to have one lady that was okay to look anything to the left. She was fine with the left. But as soon as she looked down and to the right, she had an unbelievable amount of pain, to the point it made her very dizzy, made her want to pass out. So actually, it was a case of avoiding that sequence of movement until she could then go and get her operation that she needed. Now, her operation was actually based on reducing the inflammation she had. So it was a mixture of managing treatment level and managing medications, but also about she actually had a specific injection straight into the affected ligament and muscle. So that meant that she literally had an injection straight into her spine to help reduce that pain in time. I've also had people that have had an arthroscopy, like we were talking about with spondylosis, whereby they then had the little bony spurs just gently removed and sawn off, basically. And as those are removed, they then allow more space again right in that spinal canal, reducing their spinal stenosis. Other things that can help is to allow for some stretching, massage, and any kind of lumbar and abdominal strengthening, because that can help them from placing pressure on the passive system itself. So anything whereby you're increasing that core, as long as the action of doing the movement, doing the exercise, doesn't cause more pain, can actually be really, really beneficial, just to help take the pressure off away from that sort of area on their body. So it's about taking that pressure away from that spinal canal as best as possible. So spinal stenosis is the narrowing of the canal itself, that spinal canal. Mixture of causes, could be arthritic base, could be any kind of inflammation, any kind of damage, and that will depend on the treatment for that individual and the type of programming that you give them as well. Very, very individualized based on the pains that they experience. The next one I wanted to go into in detail was spondylitis. Now I mentioned this on the previous slide, and this is because it is a autoimmune condition. Now spondy means spine and itis means inflammation, so it just means inflammation of the spine. Now what I want to kind of draw your attention to is on this image, if you look on the left hand one, that's a normal spine as viewed from the side. So you can see there's a ligament running down the anterior, down here, so you can see the ligament. You can see the posterior ligament as well, running down the posterior longitudinal ligament all the way down the outside of the vertebral bodies as well. This got the vertebral bodies with the intervertebral discs in between, and then over here you've got the actual spinous process sticking out, and the transverse process you can kind of see reaching towards you on the image. And then you can see these little red bits in between. Now they're those facet joints that I was telling you about, where they articulate between the two vertebrae. That's what allows our weight to be distributed down. Now that's a normal spine. However, with spondylitis, the joint lining becomes inflamed. It's part of a systemic disease, and these diseases are considered to be inflammatory arthritides, which means that they cause inflammation in the body, and they can be triggered by anything. They're autoimmune, so they can be triggered within the body. It could be as much down to the types of food this person eats triggers their inflammation. Now these types of inflammatory arthritides include spondylitis and ankylosing spondylitis, and this is what happens with them. So if you look now at the second image, you can see the inflammation starts to appear around the joint lining. So the joint lining is going to be here around the intervertebral discs and also on the facet joints. Now over time, based on all of this inflammation and damage and this wear and tear that this happens, and the body starting to attack itself and cause healing, it creates a self-fusion. So they end up with specific self-fusion on advanced ankylosing spondylitis. And this self-fusion basically means that they're not going to be able to move any of their vertebrae at all. So these people you often see stuck in what can look like quite strange positions. It means they don't have any range of movement at all. In younger adults, as they head on through, generally it will just appear as inflammation and chronic pain. As that person gets older, depending on how it's been managed, they may well find that they've succumbed to different postural changes that ease pain momentarily, and then they end up over time getting fused into that position. This is often where you see particularly older men, for example, or older ladies in a fixed hunched back position, and that's whereby it's been fused based on avoiding certain inflammations and then stuck in those positions. So they've found positions that cause them less pain, and over time they've actually fused those vertebrae together based on the condition they have. So it's really not a very nice condition to have, and when we're prescribing exercise, it will all be about the individual. However, because this is autoimmune, it will vary. So with any autoimmune conditions, everything from multiple sclerosis right down to particular rheumatoid arthritis, for example, all of these have peaks and troughs, which means that they have some days where they feel really great and their inflammation is really low, and they have other days whereby they feel really rubbish, they feel in a lot of pain, and their inflammation is really, really high. I would advise that you encourage your client to create a pain diary and a pain and lifestyle diary. I also suggest that this relates alongside their nutrition, because it's really important that you start to find things that cause the triggers. So I used to know someone who was pretty young. He was in his late 20s, and he actually was a Pilates instructor, which he started doing as a result of the pain that he had in his back. Now he had early onset ankylosing spondylitis, and he found that if he ate clean, he ate very well, and lots of good fats and good green leafy vegetables, those type of things, it kept his inflammation down, and he could function kind of like a normal person, a normal spine would, and he was actually very strong around his spine as well. However, if he went out, had a lot of drinks, maybe he had some food that didn't adhere to him very well, his particular thing was bread, then as a result his inflammation would really flare up, and he would almost be totally crippled the next day from it, so having to lay down all day. Now, he actually made that lifestyle choice just to say, I'm never going back to that because the pain is not worth it. But your clients may not have actually made that connection between the two. And if they haven't, that's your job as a coach to start allowing them to highlight what their triggers may be that cause the increased inflammation that they're having. They'll know they're inflamed because they will feel the pain that's associated. So balancing a lifestyle and a pain diary can be really important to finding out what their triggers might be, altering their lifestyle so they have less of those triggers, even though they still have the condition. And this will obviously affect their performance and their comfort levels on a day-to-day basis. So generally that's the rule of thumb for spondylitis, is to limit the triggers. However, outside of that, it's a case of maintaining a healthy, balanced life. So even if somebody is in chronic pain, how do we keep them from preventing sedentary actions which allow them to then progress on to coronary heart disease, diabetes, obesity? We want to keep them at a point whereby they can manage their health, and that's generally where the activity would sit, in a kind of moderate position whereby they are exercising they may well have discomfort but not up to pain, but in a place that will allow them to be as healthy as they can be to prevent future different types of conditions down the line. So this is the most common one that we will come across in the specific low back pain and nerve root pain section. Now this is disc herniation. Again, this is a really great image of the vertebra from the top. So this is a lumbar vertebra viewed at superiorly, so from the top. Now, what I really want to draw your attention to is that you can see the intervertebral disc sat on top of the vertebral body. Now, you'll notice on that disc you've got two different types of material. One is classed as the annulus fibrous, and this annulus fibrosus is literally rings of cartilage. And they're really strong rings, and their idea of this is to hold everything in place, is to be rigid. And then you've got the nucleus pulposus, and this is like a jelly kind of material in the middle. Now this jelly-like center, imagine it's like jelly in a donut, okay? So you've got jelly in the middle of the donut, and you've got the donut dough around the outside, that's the annulus fibrous. So you've got these two components together, very similar. Now, as that's sitting in between your vertebra, so in fact, just pop one fist on top of the other fist, and then imagine you've got a donut in between your fists as well. And all I want you to do is imagine that vertebra is yours, okay? So line it up next to your body so that you know that when you bend forwards, there's going to be a tilt in that motion with your hands. So, for example, I then flex forward with my spine. I'm going to tilt the point facing forwards most towards each other, opening up the space at the back. Now on this image, they're actually facing away from us. So they're facing away from us. The back of them is at the top, okay? So in this place, imagine you've got donut right in between your two hands, and you're squeezing in on one side of the donut, and you've done this before, I'm sure, when you're biting into donut and you squeeze too hard on one side, it all comes spurting out the other side. And that's the same principle of what's happening with a disc herniation, that by putting pressure forward, so in forward flexion, we put a lot of pressure on the anterior element of our intervertebral discs, which pushes all of that annulus fibrosus out through massive pressure back posteriorly towards our spinal cord and spinal nerves. Now just look at the image again now, and you can see this happening. So based on this image here, you can see that down here is where the pressure would be if we were leaning forwards. So this person leaning forwards would put pressure here, so that two anterior parts of the vertebra would be next to each other, and that would push all of this jelly-like substance backwards. Now that's why that annulus fibrosus is there. That's there to help secure that and keep it solid. However, over years and years of multiple flexions, maybe lifting massive weights in flexion, this will also be at a point whereby that load cannot be dealt with. It also might be that there's deterioration of, say, ligaments and muscles around that area, so that when they are lifting, all of the pressure goes through the discs rather than through strong muscles and ligaments. Now, as a result, that then can cause a protrusion. Now, if the annulus fibrosus is just pushed out a little bit, kind of similar to what you can see here, but just pushed out a little bit, that's classed as a disc bulge. Now, a disc bulge is where it's bulging out a little bit, but it's now putting pressure on that spinal nerve, which means that that person's going to get radiating pain right the way down through their legs or wherever that spinal nerve serves, because it's getting confusing signals. And it's non-nociceptive pain, just like we spoke about in Module 2, because it's pressing on and compressing that nerve, but not actually interfering with the receptor itself. And it's sending confusing messages which can cause shooting pain and radiating pain. Now, that's a bulge. Now, if it totally herniates, that means that gooey gunk in the middle totally seeps out through, and that annulus fibrosus totally splits open, basically. And that means that all that gooey gunk could well end up around the spinal nerve. It could end up around the spinal cord itself, in that spinal canal. And as a result, that causes a lot of pain, a lot of dull aching, a lot of mixed signals backwards and forwards, because there's a lot of different pressures around the nerve itself, which confuse the signals. Now, this is often done posteriorly. So here it's showing it as a posterior disc herniation. In fact, it's slightly lateral, to be honest, because it's heading towards the spinal cord. Posteriorly, laterally herniated. However, it's unlikely that it would be anterior, because an anterior disc herniation would happen from excessive extension, and also there's no nerves on that inside for us to feel it even if it happened. So generally, the rule of thumb with disc herniation is to encourage extension-based movements to allow and to start pushing that nucleus pulposus back in. If it doesn't push it back in, then at least it will stop it from pouring further out or from causing more damage. So really what you're looking at here is that with the herniated discs, it's often caused by forward flexion. It's often caused by lifting, pulling, bending and twisting movements, and using those same types of movements again will often cause further damage to that area. So very important to consider, if you've got a client with disc herniation, you want to be encouraging extension of the spine, which is leaning backwards, rather than forward flexion of the spine. So that's really like a great overview of disc herniation. You understand now what a disc bulge is as well, which is that little bit just pushing through. In terms of treatment, sometimes they can go in there and just clear it up, and it depends on how close it gets to the spinal nerves and spinal cord, because the problem here is that one little touch could potentially cause paralysis from there down in operation. So it's a very serious operation. So one of the operations is to literally clean up the gunk, almost like hoover it out, so to speak, and that means that then there wouldn't be a nucleus pulposus inside that disc. So that might be a choice to leave it. Generally they whip that disc out because it's broken anyway, and they will fuse those vertebrae together. So they will literally use that concrete stuff that I was telling you about earlier to fuse those two vertebrae together, which doesn't allow any movement, but it also won't allow any pain. And this can cause great relief to the pain that your client may be experiencing. So, yeah, that kind of really summarises where they are with disc herniation. The final of the real conditions that I want to go through is scoliosis. Now with scoliosis, this is a medical condition. You would have probably come across this in previous qualifications you've done. So for example, level 2, they always ask you to understand what scoliosis is. Now this is a medical condition whereby their spine is curved from side to side and it's fixed in that position. So it's not like it's just a result of postural tensions, it's actually that the vertebra will stay in that position, the vertebra in that place. Now it's a complex, it's three-dimensional, but on an X-ray it generally looks like it's shifted, just like an S or a C shape. Now this can cause a lot of pain around the surrounding muscles. It can cause a lot of pressure, causing sort of those bony spurs to occur again, so that's spondylosis, where you're getting sort of inaccurate movement of a vertebra. It can limit range of movement. Like I said, osteoarthritis and spondylosis will set in, could cause spinal stenosis, could cause a lot of nerve impingement, and really it's a case of an individual process. So some people might have a little scoliosis which doesn't affect them at all, totally asymptomatic, whereas other people may have quite a large scoliosis which makes a massive difference, and every scoliosis will be different. If this occurs in very young age, then sometimes they can put metal rods down through the spine which allows it to be totally fixed, so that will then be fused from the sacrum right up potentially to the cervical spine, depending on the level of scoliosis that's going on, in which case we've obviously got to be very careful in the types of actions that we ask that client to do, bearing in mind they don't have the normal capabilities of a normal spine. Regardless, when you're working with anybody with scoliosis, it's a case of managing the tensions around the muscles that have been created, but knowing that you won't fix that, but you can work with them from a health orientated point of view to make sure that they're maintaining their healthy levels of exercise that they need, make sure that their muscles stay strong to help support that as best as possible and alleviate pressure on the discs. So now I want to share with you something called cauda equina. Now cauda equina is a very serious but quite rare condition, and I'll show you the area that this affects. So just as we approach our lumbar, our spinal cord actually breaks down into something actually called cauda equina, which means horse's tail. And you can see that these nerves break off. Now as these nerves break off, you can see they actually aren't kind of in one nice cord, they're in like a plexus of nerves. And they break off into those final spinal nerves that come out from the side. And they integrate when it hits around the sacrum, and they integrate and then come back out via our sciatic nerve, which you can see goes through this little gap in our pelvis here. So this part here is more vulnerable. So whereas you have the spinal cord, which is a lot more sturdy, it's a lot more integrated, from sort of the lumbar downwards, you end up with this breaking up of the nerves, which is still running through that spinal canal, but it's much more open to damage. Now the other problem here with cauda equina is that if damage occurs around these down the spinal canal here and affects these nerves, is that they're quite serious nerves for it to be affecting, because that can limit and cause paralysis from, say, the waist down. It can mean that they don't have function over their digestive system, they have no control over reproductive system, they have no ability to go to the toilet on their own, they might not be able to walk, and the severity of that will just depend on the nerves that have been affected. So this part down here that you can see heading down through branches then off into the sciatic nerve and then down the leg. So when we're looking at this cauda equina, we know that if somebody has damage to that area of their spine, this bit that looks like a horse's tail, around that area, if they have damage, then it can be very, very serious indeed. So let's go back and have a look at actually what's happening. Now, it's a nerve root problem, and it's a rare disorder where the nerves at the very bottom, like I was saying, is that cauda equina nerve plexuses become pressed on. They have some pressure occurring through them. And this cauda equina syndrome may be caused by a ruptured disc, a tumour, infection, fracture, or that spinal stenosis that we were talking about as well. The syndrome needs urgent treatment. Now this is where it becomes potentially different to the others, is that you may be able to help notice the symptoms of this syndrome and allow them to get to treatment ASAP. So if you notice some of these symptoms, which we're going to go through in just a moment, then you need to progress them on towards the doctor straight away. You need to refer them straight away. And the reason for this is because you want to preserve the nerves that will then go in towards the bladder, the bowel, from becoming permanently damaged. The sooner this is treated, the less disability occurs. And actually I've had a couple of clients now. One of them came to me after being diagnosed with cauda equina. So he was actually paralysed from the waist down as a result of damage around those spinal nerve endings in the cauda equina syndrome, and he actually became paralysed from the waist down, had no control over bladder or bowel. So he was in a very different place to some people, but he was just there to help now his function as best as possible, even from a paralysed state from the waist down. And that was actually all about increasing his strength, allowing him to stay cardiovascularly fit as best as possible, and allowing him to function better through sort of transferring from chair to standing, etc. However, I've also had a couple of clients come to me whereby they presented back pain to start off with, and over time I've gone, oh, these symptoms start to look a little bit like cauda equina, and then referred them to the GP. Now, thankfully, touch wood, every single one of those have come back from the GP having been tested, saying no, it wasn't, it's all okay. But it's good to refer on, even if the doctor says no, that's fine. And actually that means that you're being very vigilant. And to be honest, you're more likely to get more referrals back when you're as vigilant as that. So let's look at actually these red flags. Now, these are red flags. They need to have more than one of these in order to be classed as potentially having cauda equina. So for example, low back pain is one of them. So already that's a given. Now if they mix that low back pain and the time of onset of that back pain to any of these other areas. So problems with bowel and bladder function. So usually unable to go to the toilet or unable to go for a wee. Also numbness in the saddle area. Now numbness in the saddle area, if you imagine you're sitting on a spin bike, it's everything that becomes in contact with that saddle area, with that saddle, that seat, then that becomes numb. And as a result, that whole numbness is a sign that generally those nerve functions aren't working properly throughout that area. Also, it can cause weakness in either one or both legs, which means they might have problems with their gait. So they have a disturbed gait pattern whereby one foot might move a lot more than another. Maybe they limp a little. Maybe they've got particular instability on one leg more than another leg. So generally the way I would phrase this is that if I've noticed, obviously my clients come to me with low back pain, maybe I noticed that they said something about bladder or bowel, or maybe they haven't said anything, then generally everybody that comes to me with low back pain, I would ask them some simple questions. Have you had any variations with your bladder and bowel control since having the back pain, or that occurred at the same time as the back pain? Now the reason why I ask at the same time as is because if you think of particularly older populations that may well have back pain from one reason or another, they then also may well have bowel or bladder problems from a different reason. They may well have problems with their gait pattern because of a hip replacement. So we've got to make sure that we can try and find a reason to believe that they are linked rather than separate occurrences or from separate conditions. So that's what you're aiming to do in that process. Once you find any of these, then you refer to the GP, telling him that you've seen these particular symptoms or the ones that you have noticed, and then he will go on and do the tests in particular as needed. When you're liaising with the GP, just make sure you're really clear that you're not kind of imposing what you feel the diagnosis is. It's just you've noticed some serious symptoms that need to be looked at. So that kind of brings us to all 7 of the specific low back pain and serious spinal pathology conditions. So we had spondylolysis, spondylolisthesis, that was about the fracture. So spondylolysis was the little fracture, spondylolisthesis was the full displacement, spondylosis, which was the arthritis type that gave us those little bony spurs, Then we had spondylitis and ankylosing spondylitis, which was the inflammation, and when that got more advanced, the fusing. Then we had spinal stenosis, which was the sort of narrowing of the spinal canal. We discussed disc herniation and disc bulging, scoliosis, and also cauda so a huge amount of information in those. Now, just before we sort of head on, I just want to explain a little bit about disc pressures, because all of these conditions relate a lot to the discs. We were talking about it particularly with disc herniation and bulging. We were talking about it in relation to spondylosis, where there is pressure and degeneration of the discs. So as a result, we need to know about the exercises we give our clients and the types of disc pressures that they put through their spine in particular different situations. So for example, let's have a look at this image that you have in front of you. You'll see that there are 6 different positions, all showing the amount of disc pressure whilst in that position. Now, disc pressure is done on percentage. So you'll notice there is a lot less when they're supine lying. Now, in that lying position on their back, their discs are able to become fully hydrated because the pressure is the least. Then you've got side lying. So somebody with a back problem or particular disc problem is encouraged to lie on their back for recovery more than they are on their side, because you can see that there is a little bit more increased pressure there. Then it goes on to standing. So now when we're standing right now, you've got 100% more disc pressure going on. So you've got 100% disc pressure. But that is considerably less than when we start to sit. So if you hop over and look at sitting, in this place you would think it would be better for your discs, but it isn't. And that's because of the amount of curvature needed when you're sitting is very different, but also all of the muscles around your glutes and your legs and your core are holding you up when you stand, whereas as soon as you sit, you actually become a place where there's a lot more disc pressure going on because of that flexion in the hips. Now think about the people that have so much pain they don't go to bed, they sleep sitting up in a chair. These guys don't get relief from that disc pressure, they don't get relief and allow that rehydration to happen because you're at 140%. They may as well be standing. In fact, standing would be better for the disc pressure than if they were sitting. So it is important to consider what exercises we give our clients so that we're limiting the pressure on those discs. There's 2 more I wanted to show you. One of them is standing with lumbar flexion, and that's why we want to avoid this process as much as possible. There are plenty of alternatives to exercises. So somebody that has particular disc problems, I'd say avoid standing with hip flexion, so they're kind of in a tabletop position, or standing with spinal flexion, whereby they're curving in their lower back, because it's going to put massive pressure on those discs as well. And then the final one that is the most amount of pressure is going to be that sitting down with lumbar flexion. And if you think, oh, I never do this, but actually clients do this a lot. If you think about in the gym when you go and pick weights up, it's very easy just to sit down and lean forwards and then lift the weights up from there. But there's a massive amount of disc pressure, and although as a healthy being that might be okay on your discs because you've got the ligaments and the muscles there to support, somebody who already has disc problems is not going to benefit from this kind of position at all. So we avoid that totally. Also, if you're having to make a choice between the types of exercises you choose, I always recommend going for a standing version whereby they can use their glutes and their back as much as possible. So standing or lying, but avoiding sitting wherever possible, because that's going to help remove that pressure off the discs. So here's a little summary. So if they've got damage to their invertebral discs, avoid seated exercises, avoid flexion forwards, encourage correct core activation, and observe and correct their posture and technique as much as you possibly can, because you want to make sure that they're not got cheeky little flexions within the lumbar anywhere. And then avoid additional loading on the spine as well. Now obviously if you think about that position from standing, if we now put an extra, say, barbell across their back, so back squatting, that's a lot more pressure again going down through the disc, so that's worth bearing in mind as well. So let's go into a little summary for how we plan activity for our specific low back pain. We want to avoid repeated full flexion of the spine, and that's based on not just the disc problems, but all of the conditions we went through actually came about that they were worse in full flexion. We want to instruct good lifting technique, never from a seated position, always from standing with a deadlift. We want to be cautious but allow for overload. Now this one's really, really important. It's important to be cautious when people have pain, and I totally understand the thought process behind that. However, you still need to make sure that you overload the desired muscle. So for example, some people go, oh, it's very important for them to work their core, so I'm going to do a shoulder press sitting on a stability ball, for example. And then they find out that the shoulder press can't be as hard on the actual shoulders because they're busy trying to work out where they are on their core. And in matter of fact, it would be much better for that client just to stand up and do the shoulder press to its maximum overload and get what they need to get out of it, and consider their back pain, but not combine the two. So it's better to get overload in the desired specific muscle and really focus on one muscle at a time in that respect, or big compound muscles, rather than trying to challenge the stability by adding in something that makes it a little bit more complex but reduces intensity. Also avoid high impact or uncontrolled movements, so anything that's twisting at speed or has fast changes of direction, because like we've said in the last module, in module 3, we're talking about that inability to activate that core quickly, and if they're not able to activate that core, then instantly they're in a place whereby they're potentially going to cause more damage. Then you're going to look at programming according to their goals. So programming according to goals is about, if their goal is fat loss, weight loss, to get faster, fitter, stronger, leaner, meaner, whatever it is, then make sure you plan according to those, but then monitor the pain and discomfort and adapt as needed. So then there are some specific medical treatments that your client will be having as a result of their specific low back pain. This is just all the medications. Now I've put them in order, and you'll see this in your manual as well. It's got some good definitions in there. Now analgesics are the normal paracetamol based medications, and these the only thing that we really need to consider from an instructing point of view is the pain masking effects that this might have, as with any of these, but also any GI discomfort. Now because they're tablet based, a lot of these medications will cause GI discomfort. So that means that they might have stomach cramping, they might have diarrhea, they might have constipation. So just consider how they feel doing certain core exercises as a result. Then we've got non-steroidal anti-inflammatory drugs. These are obviously going to be really important if people have got inflammation, and it just helps ease that off the spinal nerves in particular. Now, aside from the normal GI discomfort, these guys can be prone to fluctuations in their asthma if they already have asthma, or breathing problems if they don't, but also blood pressure variations as well. So it might affect their blood pressure, so it's always good to make sure you screen for that at the beginning. Then we've got weak opioids. Now these are actually very common within back pain, especially if people have had it for a long period of time, and tramadol is probably the most common of them, and it can be a very serious one to work alongside as an instructor and whilst monitoring pain, because they get pain disassociation, which means they have no idea where their pain is coming from, so they can't give feedback about the pain. It just feels numb, for example. They'll still have GI discomfort. They can get drowsy, nauseous. They can have muscle aches, sometimes anxiety and addictions to the opioid as well, because it is an opioid. Then you've got hallucinations and memory problems as well. So there's a huge amount of symptoms that come off of using something like tramadol that your clients need to be aware of, and that you also need to be aware of to look out for in your clients. Then we've got muscle relaxants like diazepam, and this can cause them to be drowsy, similar to with the opioids, to be honest, dizzy. Now because it inhibits the nervous system, they can lose their coordination. They might not be able to activate those muscles as well either. So this can be troublesome if you're trying to activate specific muscles and yet they're taking a muscle relaxant. And then finally we've got tricyclic antidepressants. Now these TCAs include amitriptyline, and they increase sweating, drowsiness. They can cause a dry mouth because they encourage dehydration. So make sure they drink plenty throughout your sessions. And then they also can cause heart problems and blood pressure fluctuations. So best to always continually take blood pressure tests with these as well. Now that's just a nice clear overview. The same is written in your manual as well, but I always suggest you look up the specific medications that your client is taking, so you know the specific symptoms that may happen for them. They might not have all of the symptoms, they might only have one or two, they might have none, but it's good to be aware of what the side effects are. So now let's look in at the medical treatment plan. So they may have be asked straight away to have rest and activity, which is their first port of call, same as with non-specific low back pain. Then they'll be on medication for pain relief. And then generally they go to physiotherapy and manual therapies, just like we were saying with specific non-specific low back pain. I mentioned about an arthroscopy, and an arthroscopy is where they might go in and shave off those bony spurs. That might then result in a spinal fusion. And then after those sort of interventions, after those operations, that's when they will then head into a rehabilitation phase. And it could well be your activity becomes part of that rehabilitation phase, depending on your relationship with your medical professionals that you're surrounded by as well. So activity throughout all of this is important, but again, it comes off of the treatment plan for the GP has set for them, or the specialist has set for them. So it's about working alongside that specialist throughout and having respect for the plan that's laid out. So this brings us towards the end of Module 4. So it has been a lot longer, and we've gone into a lot of detail in all of those conditions, and there are some long words in there. So I've just got one quick quiz question for you to finish up and wrap up all that information we've learned. So what is a red flag sign and symptom that indicates cauda equina? So this is one of the spinal pathologies that we did. Is it A, increased coordination, B, stiffness in the neck and shoulder, C, disturbance of gait, or D, confusion and dizziness? So if you need a moment to be able to answer it, then just pause the video. That'll allow you time to be able to gather your answers and really read through the question. I'm going to give you your answer now. So the answer is C, disturbance of gait. So like we said with the cauda equina, because that would affect their nerve reactions and the nerve impulses, it can affect how they walk. That's disturbance of gait. You might have a limp, etc. So then the tasks from here. So the tasks that I'd like to do ready for the next week that we go into Module 5 is to now start diving into your case study in a little bit more detail. And ideally what you need to do here is continue with that case study. So if you turn to pages 15 to 17 of your LAP, it will allow you to read about your case study and everything about her, about what her back pain is, and you can start classifying whether you think she's got non-specific low back pain or specific low back pain. And then I want you to interpret information and answer the questions that are on pages 18 to 23 of your LAP. Now these are basically part of that case study, so it's about how do you interpret that information. Now there may be some boxes that you're not able to totally complete yet, and that's because we've still got 2 more modules to complete. So if there's anything that's totally strange to you, don't panic about them, leave those and head on over. But I'd like you to get all the way up to page 24 that includes your SMART goals. Really, really important to fill those bits in because that will manage your time perfectly for where we sit at the end of Module 5 on the next module. So that's basically where we sit in relation to your case study. If you're having any trouble with your case study, remember you can contact us. Let's just recap where we've been today. So today we've defined specific low back pain, we've looked at 7 specific conditions, we've defined what we can do in the limit of our practice, we've looked at the treatment level for specific low back pain, and also at the very end you're now going to go away and finish up those 2 worksheets if you've not finished them already, and start work on that case study, working through those following pages up to page 24. So that brings us to the end of Module 4. If you have any questions, you can email me at info@parallel-coaching.com. Outside of that, I hope you've enjoyed today's module, and I will see you on the next one for Module 5. Have a great day ahead.